I'm really happy that you're all here today. Um, and I want to start us off in a good way. So we acknowledge and respect the Lekwungen, the Songhees, Kapasim peoples on whose territory the university stands, and the Lekwungen and Wasanich peoples whose historical relationships with the land continue to this day. And since some of you are probably joining us from other places, I encourage you to give a moment's thought to the land that you are joining from and your relationship to it and the people who also belong to that land. All right, so I'm really excited that Junko is here to talk today about her work looking at large data sets and also looking at what is happening in the community. So I'm going to go ahead and turn it over to Junko. For those of you who are new to our webinar series, you may notice that you don't have access to the chat like you normally would in a Zoom session. We instead have a Q&A button. So please feel free during the talk to put your questions into the Q&A button. We will wait until the end to answer questions. So if you're typing in, be sure to give a little bit of context so we know what you're referring to, because we may be at a different place by the time we actually answer the question. So feel free to type away while Junko's talking, and it's all yours.
Thank you very much, Karen. Hello, my name is Junko Fukui. Yes, I am uh, soon to be graduating from the School of Health Information Science. I'm really excited to be here to present my research work, application of data science on health administrative data to predict higher level of care transition. So I'm going to share my slide now. So yes, so I'm going to present this the predictive model development based on health administrative data. So the agenda here is for this seminar session, start with background of the research and talk about objectives and method and result and takeaways. So I just would like to share why I started my research before getting into this presentation. So my research journey began during my time as a home support manager, where I had daily opportunity to speak with clients, their families, and care providers about their concerns and challenges. This conversation gave me some insight into the struggle surrounding the care transitions and highlighted the urgent need for innovative data-driven solutions. I came to see analytics and decision support as not only professional tools, but as a way to create meaningful change. And I felt compelled to pursue this work as the center of my academic career. Excuse me. So, so my focus area is home support. So what is home support? So home support is a part of home and community care services. Home and community care includes home support and professional home care services. So professional home care services include like nursing and physiotherapy or occupational therapy and so on. And they're delivered by registered clinicians. In terms of home support, the Vice Ministry of Health defined home support as services to assist the activities of daily living, which is like assisting bathing, assisting meal prep, medication assisting medication and so on, so that people can live independently at home. And the service was provided by community health workers, also known as CHWs, at the service client's home, so that client home support client's home. So home support often supports old adults, and the increase of the aging population is changing healthcare system really globally, including home support. So, for example, people who are 60 years of age and above were about 12% of the world's population in 2025, and it is expected to increase to be by 22% by 2050. Just focusing on British Columbia here, 26% of population was 60 plus years old in 2024, and this is expected to increase to 30% by 2046. This very old number, but this is the newest data I could get. I mean, the future, most future data I could get. And then WHO indicated that 70% of the people who are 60 and above are likely to need support with activity of daily living, which is provided by home support services. So the demand on home support services is expected to increase as the aging population increases. Now let's focus on BC home support. BC home support is facing some problems as the population of older adults increase. The demand for home support has been increasing. However, funding and resources to support home support services are limited because of increasing demand and limited resource. The eligibility criteria for home support has been stricter than it used to be. And the limited resources are not only for home support services. The service of supply for long-term care bed is also inadequate. So what happens as a result, people who need long-term care beds tend to stay home with home support, and the acuity of home support clients become higher. And the CHWs who provide services are not always trained for higher acuity home support clients. And also, due to the increased demand and resource limitation, clients do not get adequate home support service time. Finally, all these challenges together are increasing the family caregiver burden. So in order to sustain home support services, home support managers need an evidence-based decision support tool for care planning and resource allocation. So now, in terms of the research in the area of home support clients care transition, a total of 11 studies are found through a systematic review and a follow-up literature review between 2019 and 2025. The studies identified here focused only on one single transition destination, like to the hospital, to the residential care. They didn't really look at across the different destinations. And based on the review, I came to the conclusion that we need a practical model and which handles time varied factors with multiple transition destination in a health service. So for this, for support both care planning and resource planning. The research objective was the research objective and hypothesis. The objective was to develop predictive models of higher level care transitions, with multiple locations among home support clients for evidence-based decision support. And then particularly focused on what were the key factors that were associated with the higher level care transitions within a certain period of time from the start of a home support referral. The hypothesis was the administrative data would allow the prediction of transitional care for home support clients. Now, this slide shows the care transition destinations that were included in this study. So everyone starts from home support, then whether they're going into hospital, residential care, or assisted living, or end of life care. And in some cases, people are leaving home support because they are doing well and they can function without any more services, or they're moving out from the province. So then those people are considered as no service required. Now, as the title said, applying health administrative data to develop a predictive model. So just to talk about what administrative data. So administrative data is basically it's a secondary data. So these data sets are readily available to use, but the data was not collected for research purpose. So it was collected for administrative reasons. So it requires to think about what we can do or use or derive based on what what is available from the available health administrative data. Now here, this is what I got from a local regional health authority. So I received 7 data sets from the local regional health authority, and the data sets included home support clients data. This is like the age and gender, home and community care referral data, discharge abstract data set. This one is for hospital inpatient and same-day surgery, emergency depart visit data, professional home care encounter data, which include when the professional home care providers visited, or date and the type of professional, what type of, is that nurse visit or physiotherapist visit, that kind of data. Home support visit encounter data. This is similar to home care, professional home care encounter. Home support CHWs when they visit, date and time and duration included in a data set. And also home support care plan data. This is a prescribed service for a client, home support client to receive, such as I mentioned, meal prep assistant, medication assistant, bathing, and so on. And when they receive, morning, lunchtime, afternoon, evening, or bedtime. So data set ranged in a size from 35,000 to tens of millions of rows. And I linked the data set and prepared the research cohort. At the end, I had about 13,000 referrals based on 10,000 clients to work from for the research. And so overall cohort is the long-term home support client who are 65 plus years old at the start of home support referral between November 1st, 2019 and March 31st, 2023. And I also need to mention that the analysis and model development were based on the home support referrals rather than home support client. It is because we had only 2 years of data overall, so it's just hard for me to follow people around because people tend to stay in the healthcare system very long time. So home support referral was the focus here. So by linking the administrative data, we can recreate the healthcare system journey of the cohort. So I had 7 data sets, and I linked together what I wanted to achieve is this. So home support referral data will give me the referral start and end, and the home support visit data. So that's an encounter of the CHWs. When did they visit, what time, and how long? And then home support care plan data is when did this when the service has to be provided, morning, evening, and what type of services has to be provided. And then care plan can be, as long as 2 weeks, and they can add more care plan or they can remove care plan. So it's not really, it's kind of almost random because then I have to reconcile what kind of service were provided at the time, at a certain period of time, and when the certain services are removed at a certain period of time. So we have a good picture of what people are getting for every day and the time of the day. And now professional home care visit is who is visiting and when they're visiting. So the CM is case managers. His managers may be visiting 3 times during the referral. OT visit at the beginning of the referral because they have to adjust the evaluate where people are living. PT maybe PT as a physiotherapist, maybe assisting the physical movement and stuff like that. And then emergency data can tell me when they had an emergency visit. And sometimes people are hospital during the home support referral. So we can get some idea of when that happened. And of course, we have to know where they are discharged. Is that to the hospital or long-term care or other type of care? So this is not really a complete picture of a client healthcare experience, However, it is exciting to think about what we can do with the available data and what type of analysis we can conduct to answer our questions. And also, I think we should remember what a privilege it is to work with data that represent people who have been through health challenges. I really want to emphasize how important it is to use the data ethically and respectfully to those people the data belongs to. And also the data, also this is like clear map of, what happened, but actually data is never completely clean. You need to budget a lot of time to assess the available data to be ready for the analysis. So I'm gonna talk about what I did, a few examples. So for example, some of the home support fields for the same person overlapped, like this. Before the previous service ends, next service started. Or sometimes there is complete overlap. So I have to kind of clean up this type of referrals. So for example, in this case, oh no, sorry, I just talked about that. So this is what I did. So if the services are different, so home support has two types of services, short-term and long-term. I just focused on long-term care. But if this first service was short-term and second one was long-term, I cut the short-term referral and then I just the start of the long-term referral is the end of the short-term. So I just made sure to do that. And then for this case, if they are overlap and they are the same type of service, i.e. long-term home support, I combined all of these and then made it to one referral. Another type of challenge that I had for data preparation was to identify, excuse me, the destination at the end of the home support referral. So home support referral, sorry, home support referral data. Sorry, I'm just gonna go through this everything here. Here we go. Home support referral data contain the discharge destination. However, the recorded discharge destination were not directly from home support, especially when the clients were admitted to hospital. So home support referral often did not seem to be closed until the clients were discharged from a hospital or the people are considered not likely to come back to the home support soon. So the referral is left open for a while to evaluate whether this referral should close or not. So as a result, the discharge disposition from the hospital often was used as a discharge location when home support referral was closed. So if home support client was admitted to the hospital here, and they should be the discharge destination was recorded as a hospital, it should be, but tend to be like residential care or end of life or death. That's how it was recorded because the hospital data recorded that way. So that I had to rematch that destination that way. Finally, one more thing related to that, and finding the actual end of date of home support referral for a hospital admission was another challenge. So the perfect data set is, the top arrow, the referral ends and admission starts, but that rarely happens. Usually we see some time between the home support referral close date and the home support admission date, or the home, sometimes hospital admission date was before the home support referral ends, as I mentioned earlier. So for data cleaning purpose, if someone was admitted to hospital from home support within 24 hours, and the hospitalization was considered as a care transition related to the home support referral case. And then also this 24-hour window was determined based on BC government's home and community care policy for safety. So if there were more than 24 hours between the home support referral and the hospitalization, the transition was not considered as a transition of care in this research. Another type of challenge here is that whether home support client actually moved on to hospital or just had a temporary admission. So in other words, whether home support would be closed for hospitalization or temporarily put on hold for hospitalization. So assuming that client will return to home with the same home support referral. So people are assumed to be returned to home support with the same referral if the home support referral was not closed by the time they were discharged from the hospital. So this case, like this small arrow, orange arrow, and the home support was still open. And also there are records of home support visit after the hospital discharge. Otherwise, the client were considered as having moved on a higher level of care, even if their home support referral was still open. Now, I have a few more challenges for data cleaning, but I'm not going to share anymore here. It's just so many, but I needed to spend a lot of time cleaning. Anyway, after the data had been mastered into a good shape, the analysis were conducted. The steps that I took to conduct this research was the first, I conducted preliminary analysis based on a subset of clients. The client included here were those who were hospitalized during referral and investigate the factors that were associated with hospital transition, not returning to home support. In this step, survival analysis was used. And then after that, machine learning model were used to identify the influential factors associated with a higher level of care transition. Then finally, based on the factors that were identified by the machine learning models, I developed a model to identify the probability and the risk of transition to higher level of care from home support using a multi-state Markov model. So I'm just going to talk about each step bit by bit, just to explain what it is. So the first one was to identify the risk of transition to a higher level of care for home support, for hospitalized home support. So as mentioned, I did this analysis and I used the survival analysis. This analysis included only the client who had a record of hospitalization during the home support referrals. The time period that was looked at was between the start of home support referral and the hospital discharge date. The factors that were associated with the hospital transition were studied. So in this model, I included 6 factors. And this one is age at the home support referral start, emergency room visit in the last 12 months, average home support hour per day in the last 12 months, records its sex, hospital admission in the last 12 months. Besides this, the hospitalization I looked at, and case manager visit in the last 12 months. So the result here is shown here in the slide. So based on the Kaplan-Meier model, 50% of home support clients who were admitted to hospital during their referral were expected to move on to a higher level of care by about year 4. So they stay in home support for 4 years and move on, 50% of them. And then based on the Cox proportional hazard model. Now, 3 of the 6 factors that I included in analysis violated the assumption of this hazard model, so I eliminated from the analysis. And the final model included age at home support referral start, emergency room visit in the last 12 months, and average home support hour per day in the last 12 months. And the risk of transitioning to a higher level of care at home hospital discharge will increase by 2% as a client ages by 1 year, and also increase 10% if there were no emergency room visit in the last 12 months. And so that means if you visit the emergency room, the risk, the lower risk associated with that. And in addition, if an individual is getting more than 1 hour of home support service per visit, on average, the risk will decrease by 13%. So that's just my preliminary, just understanding what's going on. So I moved on to next step, which is looking for identifying the influential factors that were associated with higher level of care transitions for home support client. Here, multi-level machine learning models were developed. And the method I used here is the XGBoost model and random forest. I'll briefly talk about that later. And also, we looked at multi locations here. So as I mentioned, like starting with home support referral, whether they are going to hospital, residential care, or assisted living, end of life, or they don't need service anymore, so they are moving out from the home support. Also, I divided the model into year, two timeline, window timeline. Anyway, so the first model was based on the year one model. So we only focused on first year. So where it was the destination of home support referrals at the end of the first year. And the year two model is the same idea, but where is it at the end of second year? The factors are included in the model. So I have 40 factors included for year one model, including demographic information and the home support prescribed tasks, which is daily frequency, just like meal preparation, bathing assistance, continence, and so on. So what's the prescribed for the people to receive at home? And home support duration per day and per visit. So this is, you may wonder why I did that way, because sometimes a lot of visits are not same length. Some of them are longer than others visits. So morning visit can be 1 hour, but evening visit can be 30 minutes. So I wanted to know the average of per visit and also average per day, just sum up the total visit of the day. And healthcare use within 1 month of the referral. So like hospitals. Elective and urgent, no, sorry, home support use, I think. And the elective and urgent hospital admission during the study period, ED visit frequency during the study period, and counts of home care professionals visit over the study horizon. So year two, on top of these 40 factors, I added 15 more factors. So total 15 factors, 55 factors. 15 additional factors are the change in the home support prescribed daily tasks frequencies between first year and second year. What is it? So maybe first year, somebody used to get meal prep only once a day, just for breakfast, but maybe the health condition slightly deteriorated. So the case manager decided to add more meal prep. So instead of once a day, now becomes 3 times a day. So the difference was the one that I included as a factor. So this is the discharge location of a home support referral included here. So a lot of people are remain in home support at the end of year one and year two. And for year one, slightly more people are admitted to the hospital compared to year two. But for the year two, slightly more people admitted to residential care compared to year one. And three steps were taken to develop these models. So model development include cross-validation, missing data imputation, and oversampling to address unbalanced data set. In terms of model performance evaluation, after model was developed, 6 measures were used to evaluate the model performance here listed here. And after the model development, factors that were associated with a higher level of care transition were identified based on a value called sharp values. And then the machine learning models that I developed is based on random forest, classifier, and extreme gradient boosting, so-called XGBoost classifier. And the random forest it produces a categorical output classification by generating multiple distant trees. The classification is done based on voting by all the trees to achieve the best and better accuracy in prediction. And XGBoost it develops better trees sequentially, correcting error of the previously developed tree. So I compared the performance of these two different models, and the XGBoost models outperformed the random forest models for both year one and year two. So the result you see after this is based on the XGBoost model. So what is this? This is a bit too busy on the screen, so anyway, I'll tell you what it is. This slide shows a sum of the top 20 factors among 40 or 55 that were considered influential across 5 destinations for year one and year two. The column here indicates the destination at each year, and the cell color indicates the direction at risk. So blue means reduce the risk, and red means increase the risk of transition to this higher destination listed here. The number in each colored cell ranks of the influential level on the transition to each destination. And then this rightmost column shows how many times the factors appeared as the top 20 important factors in these models across year one and year two and all the destinations. So, for example, here, more frequent professional home care visit here, the top 1, 2, 3 rows, show an association with a lower risk of transition to higher level of care from home support, except case manager visit for residential care and assisted living, and then nursing visits for end of life care. So you see a lot of blue here for the home care visit or professional home care visit. Now, let's look at home support and prescribed visit down here. More frequent home support service visits were associated with a higher risk of transitioning to higher level of care. You see more red than blue. Finally, hospitalization is right below the professional home care visit. During the home support referral was associated with a higher risk of transitioning to higher level of care. You see more red. So some of these factors were included in the next analytic steps with a multi-state Markov model. So finally, the last step was to identify the probabilities and risk of the transition to higher level of care. So as I mentioned, I used the multi-state Markov model. So just to quickly touch on what's Markov model. So it is a mathematical model that can represent system which evolves from one state to another with a probabilistic nature. So it's composed of a state called Markov state, which represents the state of a system at a given time point. Multi-state Markov model allows the inclusion of covariate and sensor data. Pure Markov model doesn't allow that. And assumptions for this Markov model is a finite number of state in the system. So you cannot have infinite number. You have to come up with a finite number. And also Markov property, a future state is affected only by the current state. So whether you are going to move on to stage 3 from stage 2 is only what happens in stage 2. So when I mentioned that too, so this is like what happens in Vegas stays in Vegas concept. So Markov knew that many years ago. So that's you're not going to carry over from the previous state, but you just what happens here will only affect your decision on where you're going next. Also, absorbing state is a state which cannot be left once you enter. For example, death. You cannot be alive and come back to stage 2. So stage 3 this is an absorbing state. But stage 2, they can go back into stage 2, or they can move on to stage 3, or they can go to stage 1. Stage 1 also can stay. They can stay in stage 1, or they can move on to stage 2. But they cannot go to stage 3 because there is no arrow. So this particular research included 5 states here shown: home support and hospital, residential care, assisted living, end of life, and no service required. And then again, this one is based on a referral-based model. So once the people move to hospital, referral close, and then they cannot come back to home support because we have to open a new referral. So these movement, they never be able to come back to the home support. So these hospital, residential care, assisted living, end of life, and no service required, all states are considered as absorbing states. And then only the time referral is still in the home support, they can return back to home support. All the referral starts from home support, of course, because we focused on home support referral. Factor included were those which are top 20 and appeared more than 7 times across the destination and the years in the machine learning model area. So you saw the big table with lots of cars, and I just picked 7 times. And then, so that included certain factors. That's, I think, enough to consider anyway. So that's what happened. And here is, I want to talk about here, this section on the right, show how the location of the referrals were determined. So type 1 referrals are the one which closed before March 31st, 2023. So we know where they ended up after the referrals closed. And then we checked, this model is developed, the location, to check the location of individuals with the home support referral at, every 6 months from the start of the referral up to 24 months. So I should have said that. So I'm sorry, oops. So here, the referral 1, they closed before the 6 months reached. So, but we know the destination. So we assume that this person is in the destination at the point of 6 months from the beginning, at the end of the 6 months from the beginning. Referral 2, at the 6 months, end of 6 months, still home support, but they are discharged. This person is discharged to somewhere else. So this is the destination or where they are at the time of 12 months, things like that. And in type 2, these case referrals are not closed. So they are considered a censored case. Again, multi-state Markov model can handle censored state. So they are not really considered for the first year because we don't know where they are. But if they're this referral 5, they open more than 1 year. So we know the first end of the first 6 months, we know they are in home support. and then end of the 12 months, we know still in a home support. So type 3 is the referral that is very long, over 2 years, and but we don't consider beyond the 24 months, so we just check every 6 months, and all the time they are still remaining home support. Okay, so next. So this is how these models were developed. First, a baseline model, which did not have any covariates of factors, was developed, and as well as the models with single covariates were developed. So total of one baseline and 13 models here. So a total of 40 models developed. Then I ranked the models according to the model performance, which I used, which were assessed based on a Kaike information criterion and the Kramer's B measures. Then this model was developed based on backward steps, and then ranking the how I remove the backward step is based on the rank that were identified in the step 1 based on Akaike and Kramer's fee. And then final step is a 5-fold cross-validation at 6 months horizon was performed. And then Breyer score was used to evaluate model predictive accuracy. So the final model included 12 factors out of the 13 factors that were started with. And the model identified the transition probabilities of home support clients at every 6 months since the referral starts. What transition probabilities is the probability of remaining home support and moving to hospital at every 6 months. So let's take a look at it. So at the end of 6 months, 68% of probability that people remain in home support, and then 10% moving on to hospital, 5% moving to residential care, 6% moving to end of life care, and then 11% left this home support service altogether. And 12 months is 46% remained in home support, and 70% moved on to hospital. And 12 months for the residential care is 8%, and 10% for end of life, 90% for no service, and so on. And then by the time 24 months comes, only 21% remained in home support, and 25% moved on to hospital, 11% moved on to residential care, 50% moved on to end of life, and 28% moved on without home support, any services. And this slide shows the 10 factors that were identified as statistically significant on risk of transition to higher level of care. I said 12 included, but the hazard ratio appeared to be only 10 that are significant. So the column indicates the destination of home support referral, as just like before, and the color indicates the direction. So red means increased risk, and blue indicates the lower risk to transition to higher level care. And then these brackets here in factors baseline. So home case management visits are associated with a lower risk of higher care transitions, except residential care and assisted living. However, nursing visits are associated with increased risk of higher level care transition, except residential care and assisted living. And home support duration per day were associated with increased risk of transition to residential care and end of life. And also having home support cleaning visits reduce the risk of transition to residential care and end of life. And actually, there's no cleaning service included home support, but some you need some special case. They have a special subscription for the people who needs for safety cleaning. And I noticed that lots of safety cleaning included in the service, so I grouped them together and included as a factor, and they appear to be significant. And having medication assistance, counseling, and personal hygiene services from home support were associated with increasing the risk of transition to residential care and assisted living. So, takeaways. An evidence-based decision support model was developed for home support manager in this research. So routine administrative data can be turned into a computable, probability-based insight on a transition from home support to higher level care. The model can generate actionable signal for planning and care management. And the research identified the importance of the regular case manager's visit. So case manager's duty include assessment of healthcare and social needs, care planning and goal setting, plan implementation, and also monitoring the implementation plan and support the transition patient in a healthcare system. So case manager visit can reduce the risk in a transition to hospital and end of life. For example, one case manager visit in 6 months was associated with 30% lower risk of hospital transition and a 63% lower risk of end-of-life transition over the 6 months. And then, however, residential care and assisted living care require more support from care managers. This in the This risk indicated that one case manager visit in 6 months was associated with increasing the risk by 30%, while twice or 6 months would increase to actually to 90%. I didn't mention that I didn't show the number here, but that's what I found out. So this may be because home support clients who are likely to transition to residential care and assisted living require more support from case managers, so they have to spend more time with the client. Also, study identified that being hospitalized during a home support care was associated with a 154% higher hazard increase for a hospital transition, 23% hazard increase for residential care assisted living transition, and a 31% hazard increase for end-of-life care transition. So home support managers and case managers need to pay attention to the health condition of home support clients who were just discharged back to home support from hospital. Study also identified the association between the influence of a frequency of home support services and the risk of a higher care transition. Overall, having more than 30 minutes and ideally 1 hour for each visit were associated with a lower risk of higher care level transition. And according to the Senior Advocate BC, about 60% of home support clients in BC receive home support service for less than 1 hour per day. And about 25% of clients are likely to receive 30 minutes of home support service per visit. And I just have to remind that this service amount of service, like 60 minutes or 30 minutes, actually includes 10 minutes for CHW's travel time. So even if you receive the 30 minutes home support service time, you actually get 20 minutes of services. In addition, suggested time allocation for each home support task varies across the 5 health authorities in BC. So for example, no, I didn't mention that here in the slide, but the time allocation for bathing is suggested to be 15 to 45 minutes in 2 regional health authorities and 60 minutes in 1 regional health authorities, according to Senior Advocate. So the quality of service and client experience would probably be different if you have only 15 minutes compared with 1 hour to bathe. And also, home support client receives not only one service every time CHW visit, they receive multiple. So imagine only 20 minutes service available and CHWs have to provide so many services. You know, I wonder if 30 minutes or 1 hour would be enough for people health to improve their health and well-being of home support clients and their informal caregivers. And implication in health informatics and future healthcare system based on this research. So healthcare is shifting toward community and home-based services. So the study can be foundation embedded in a digital workflow to support risk-informed, coordinated care at home. And this can be part of a care management plan. And also Canada began to standardize and connect health data. So as the data become more standardized and accessible, richer and timelier information will flow into routine decision making. Now, limitations for this research is the limited availability and quality of data. So this study could address only up to 2 years since the home support referral started. The system and database are not linked yet, so a lot of reconciliation of some variable had to be done. And then I noticed some human errors and data entry issues. So the misuse of system. And then clinical data, like ADL assessment data such as LAI and primary health data are not included in this study. So that big piece is missing here. And the external validation of this model has not been yet conducted. Now, future studies, the development of decision support algorithm and implementation based on the predictive model, linking with the clinical data, like within an electric health record. The role of case managers and CSWs and how they spend their time need to be further studied. And also finally, standardization of home support definitions and the standardized evaluation on aging population, cognitive, and the physical functionality internationally to enhance the monitoring of the health and wellness. This one I discovered in a systematic review. Multiple countries has different way of calling home support, different names, and the measuring the cognitive level in a different way, a different method. So it'd be nice to have a standardized this area. I included Santa Cruz. Santa Cruz, maybe they need activity for living, otherwise kids cannot get. Anyway, so finally, acknowledgement. Thank you for this. Dr. Rajsari, Dr. Courtney, Dr. Purpose, Ellen House, and Elder Care Foundation, Dancing Third Party Endorsement Fund, and UVIC, and used to be Social Development, now the Health. I appreciate their support to complete my research work. Now question time. Thank you very much for your time.